So far we've gone through the traditional ways of motion palpating the middle, lower, and upper thoracic spines. You guys practice that and you look pretty good doing it. I'm just going to show you a procedure technique that you might not have been exposed to yet that's very useful in helping you to further evaluate that upper thoracic area. So if I have my patient protrude their cervical spine like that, what motion would you say is taking place up top? Flexion or extension? Extension, right? And down here, flexion. And the opposite occurs when they retract, right? The upper cervical spine is flexing and the upper thoracic spine, C7 through like T4, is going to extend, right? So I can use that to help me palpate. And here's how I'm going to do it. I'm going to take a digital contact. I'm going to use my thumb at C7, all right, T1. All right. Either thumb will work. I think this will work better for the camera. Just place my thumb right in that inner space and have my patient protrude. And I should feel some nice flexion. I should feel the inner spinous space open. I can even apply a little overpressure. Now come back. Right. And when he comes back, try and bring it back a little further. It should extend. I should feel the spinous process push back into my digit. Right. Come forward again. Flexion. I'm not applying overpressure with my contact. I could apply a little overpressure with the hand on the head and come all the way back and bring it back a little bit further. I should get pushed backwards a little bit. And in this case, I'm not really feeling too much of that. Come down another segment. So T1, T2, and come all the way forwards. Nice flexion. Now come all the way back. And again, not feeling too much extension movement there. Come all the way forward. Opens up nicely. Come all the way back and tuck it in. And again, not really feeling that spinous push back into my hands. That's a lack of extension in the upper thoracic spine, which is more common than a lack of flexion. Most patients flex pretty good. Perhaps they flex even too much and don't have enough extension. So that'll help us decide what sagittal plane movement the patient needs. More often than not, it's going to be extension. You'll have the occasional patient with a really flat spine. That's going to need flexion instead. This is important clinically because when this area is locked up in lack of extension, it can cause hypermobility in the mid-cervical area. And that's that mid-cervical area that often becomes the symptomatic portion of the cervico-thoracic spine. You'll see a lot of degeneration taking place at C5, C6, C6, C7. And when we measure range of motion in the cervical spine, we want to count how that upper thoracic spine is contributing. And this palpation will also help us to do that as well. Now, in decision making in terms of what to manipulate and how to manipulate and what to adjust first, the primary movements you're concerned with is your sagittal plane movements, so your extension, your flexion first. And then secondarily, if the patient has coronal plane, lateral flexion, transverse plane, rotational restrictions, then you want to tackle those next. Those would be your secondary objectives, to restore motion in those areas. We just palpated flexion, extension, lateral flexion, rotation in the upper thoracic spine. Here's an additional way to couple some of those movements, right? So when I flex the head forward and bend it to the right and turn it to the right, that's a coupled motion for that upper thoracic spine. And I can palpate how that is occurring, motion palpate it, to see if there's a lack of that coupled movement there. So what I'm going to do is place my digit, my thumb in this case, right over the C7, T1, T1, T2 joint. And I'm going to place my elbow on in this case, the right shoulder, a little bit of flexion, a little bit of lateral flexion, a little bit of rotation. Just kind of load the joints up in those combined movements, and then apply some P to A pressure. Right? Come back to neutral, come down a level, flexion, rotation, lateral flexion, and add some P to A spring over the joint. come down another level, perhaps a little more flexion, a little more lateral flexion rotation. Use your elbow as a counterbalance here and add that P to A pressure for your coupled movement. I'll show this on the other side so the camera can see both sides of this. And you guys can see it too, perhaps better. There's my thumb on the right, C7, T1, inner space, right? Not in the midline, I'm on the right side. Elbows in front of the shoulder, flexion, rotation, lateral flexion, and I add that P to A spring. Now by comparison, I thought the other side was okay. The other side is actually stiff compared to this side that I'm palpating now, the right side. Come back to the center. Come down a level, I'm on the right side of the spine, and I'm springing P to A. We're going to do a series of cervico-thoracic adjustments, and again, we're going to start off with the most important motion to put in there, which is going to be extension. One of the best ways to put extension into the upper thoracic spine is with a supine thoracic adjustment. It's advantageous because it allows you to get a very strong tissue pull into extension, and it naturally promotes extension when the patient's already supine. So I'd like you to bend this knee for me. Is it okay to demonstrate this when I get to that part? So we're going to cross the patient's arms, and we're going to place the headpiece so that the cervical spine is at least neutral, not flexed. We don't want the headpiece, we don't want the neck to be flexed, because that's going to promote flexion up there and make it more challenging for us to get any extension. So we're going to keep the headpiece down. We're also going to make our contact in such a way that I'm going to take a tissue pull from starting way above the contact and very strongly down using my body weight to grab on to C7, T1, T2. And that motion alone is going to give me quite a bit of what I need for this. All right. So the contact can be, in this case, on the right side. Okay to open you up here? It can be on the right side. And just grab onto your gown right there. Or it can be in the midline. Right? Either way is going to promote extension. Very little lateral, very little rotational component to it. You can use just a bunched up thenar contact like that, or you can use a closed hand. Right? But the key for this is to really start up by the cervical spine, right? And take a very strong, and I'm going to exaggerate this a little bit so you can see how strongly I'm pulling my patient down. All right? So kind of using my hand like this, grabbing that upper thoracic spine and giving it a very strong pull down. Once I'm there, I can cut my hand if I prefer. I'm going to hold the elbows down. I'm kind of coiled up here, right? And I'm ready to kind of launch forward. I'm going to launch forward right towards the side of the patient's head, right over my contact. I'm going to use my body weight to actually perform the adjustment. So I come up and just over the contact like that. Okay? Just aim it over just like that. All right? You can use whatever percentage of your body weight you would think would be appropriate to create that extension movement. On older patients or more fragile patients, I'll do this with just like a little bit of my weight, a little bit more depending on their ability to handle the thrust. I can also use this same technique for the upper ribs, T2, T3, T4. Just take the contact out laterally a little bit. So instead of being in the midline and way up high, I'm just out in this case to the right a little bit. Right? Thenar, bunched up thenar, right over the costotransverse joints. I still take a tissue pull, right? And I still use my body weight to launch, but notice how I'm going to launch towards my hand, not towards the patient's head. So I come over and I launch in that manner. All right? So those are two very effective ways to move the ribs and also to move that upper thoracic spine and extension. I know some of you love thumb moves and some of you aren't so fond of thumb moves. And some patients probably aren't that fond of thumb moves too, because If you remember when we were doing the counter-rotational joint play palpation, if you're on the tips of the spinuses, that's going to be uncomfortable for the patient. So you want your thumb contact to be very comfortable, right? So the way to do that is to, first of all, use your whole thumb index web on this side. Just use your whole thumb index web to make that contact, right? And don't put your thumb right next to the spinous. Leave a little room, right? Because what's going to happen is when the patient turns their head, their spinous is going to come to you, right? So there's a few different ways to do this, all right? We can just incorporate counter-rotational rotation. That was like redundant. Counter-rotation, all right? I'm going to step up so that my knee's right about the level of the cervical spine. I have my contact in place. I'm going to have you lift your head up and turn it all the way to the left, all the way, and just rest it on the table. Now I haven't moved my thumb. It's still right next to the spinous, except it's a little closer now because the spinous rotated towards it. And from here, is it okay to just do a demo on this? From here I'm going to take my hand, place it over the occiput, the rest of my hand's covering the side of the head, and I lean in close, my forearm's resting right on my thigh, my lower thigh, and it's just a nice little thrust across like that. All right, come back to the center. If I wanted to incorporate some lateral flexion into this, what I could do is maintain the same contact, bring the head over, right? If I need to, bring that down a little bit. And I have a number of choices here. I can use my hand on the side of the head. Again, just it's the same adjustment really, just incorporating that lateral flexion. Or I can use my hand on the forehead and my forearm on the side of the head and use that as my auxiliary contact. And it's just that HVLA. It's gentle, it's a nice move. I think that, turn your head back in the center, I think that some docs that don't like this, I think they're pushing too hard with their thumb. That's what I think is happening, and they're hurting their thumbs. It hurts the patient, and just because of that, they're not getting the results they want to see with that adjustment, so they kind of shy away from it. But with some practice, I bet it could become one of your favorite moves. A variation of that, especially for those of you who have thumbs that are hyperflexible, you can do the move similarly by not even using your thumb. So I can just place my hypothenar right on the C7, T1, T2, T3, little bit of an arch, right? Pick your head up and turn it all the way to the left, just like we did before. And it's the same adjustment, just traction on the head and just add the thrust as you traction both partners out. All right, just turn your head back in the center for a moment. We can also perform this move from the superior. It's actually one of my favorite ways to do this. What I'm going to do is bring the leg back on the side that's contacting, making the contact. That's like your power move. You can engage your hip better if you're bringing that leg back. Now you might not think about that, it might not be comfortable, but try it sometime. Try always using having the hip on the side that you're contacting back.